Hello, I'm Dr. Flug at Flug Family Chiropractic, located in Springfield, Illinois. Today I'll be talking with my good friend Dr. Sankey. I know him from chiropractor school. We actually started in January 2013 and graduated together.
Sure. Yep. My name is Dr. Clay Sankey. I'm a chiropractor in Charlotte, North Carolina at True Motion Therapy. Like Ian said, I graduated with him, and I think we can both say that we've been grinding, you know,
Absolutely.
riding out this grind to try to open up our own practices. So,
Today I want to begin talking about just movement in general.
yeah, so I think traditionally chiropractic has been very passive in nature. So patients pretty much come into the office and they lay on the table and they get adjusted. Some of the newer chiropractors in the early 2000s, maybe later 90s, started some soft tissue work and stuff like that, which is all great, but it's all very passive. The new push has been to incorporate more movement in with care, and the importance for that is our brains need to be active to recognize the changes that are made to our body. So whether it's an adjustment to improve motion or neurologic function, whether it's soft tissue work to try to improve tissue health or blood flow, it's important to lock all those changes in with movement by involving the brain and involving the central nervous system. It'll just ensure that those changes are much longer lasting, and it's more fun for the patient too, because ultimately, what do people come in with? They come in with usually injuries due to either not moving enough,
Right.
moving improperly, or moving too much in a certain way. So to address those movement related issues, we need to move the patient. So I think that's the best explanation for why movement fits in our toolbox as chiropractors, as therapists.
Absolutely. And I love what you said too, because it's all about this input into the central nervous system. Everything a chiropractor does is just trying to stimulate the central nervous system to make a change throughout the body.
Totally.
And I also like what you said about teaching someone how to move, because, the biggest, I guess, what I love most about chiropractic is the fact that we have this opportunity to teach a patient how to change their life, and then we put the responsibility in their hands. So, you know, it's obviously a big process. It's a build up to try and get someone to optimal movement. It usually takes a long time, even with dealing with athletes or just the average population.
For sure. And it is about empowering the patient to do their own thing. You don't, as much as it would be great to have people coming in every day,
Right.
that might not be the best for the patient, because we don't want to create this dependency on us. We don't want them to feel like they have to come to us in order to be healthy. The ultimate goal of our profession should be to give people the tools to do things on their own. So walking people through different movements, it teaches them responsibility, that they can make changes in their body. My favorite success stories in the office are ones where I don't even touch the patient,
Wow.
and they go through movements and are able to say, oh, wow, I'm able to make these changes on my own. Obviously, I do like to use my hands. I mean, that's why I'm a chiropractor. So,
Absolutely.
people always get some sort of manual therapy, but the fact that they can do movements to change their pain, it's like a light switch in their head, and you get so much more buy-in that way.
Yeah, absolutely. Like you said, with buy-ins, you're basically saying that the patients find out early on that they need to invest their time and energy into what you're doing, and then you both work as a team.
Totally,
Yeah,
totally.
absolutely. Um, and I'd like to dive into manual therapy just a little bit more, or soft tissue work. Um, I know a place I like to begin is the diaphragm.
Sure.
And usually, what I tell patients is, interestingly enough, the diaphragm seems to be the place where tension is stored first,
Mhm.
and often where tension is the hardest to get to, because the diaphragm is in such a deeper, non-superficial area location inside the body.
Mhm. Yeah. I don't do a whole lot of manual therapy on the diaphragm itself. I know a lot of people who do. Um, you know, I think any kind of manual therapy done on it is to decrease the tone of it, right? So
Yeah.
it's more of a neurologic input to it. And if somebody is, if I feel like if they need some sort of release, quote release on the diaphragm, it might be hard to get to the diaphragm with your hands. They will most likely guard you. And
Yeah.
I could be totally wrong with people who do more manual therapy on the diaphragm. I just don't. If somebody comes in a situation where it seems like they need some diaphragmatic work, they need some abdominal wall work, I'll work through breathing with them. So again, it goes back to active stuff. So we'll address proper breathing in whatever position is easiest for them, and that tends to allow the diaphragm to do its job a little bit better than me trying to dig my hands into
Right.
it. So I've tried, and I just find that getting the patient to actively do it themselves and start breathing. And by working on breathing, you are decreasing the sympathetic drive in the nervous system and you're increasing the parasympathetic drive. So it's doing so much more than just trying to relax a muscle. It's affecting the system as a whole. And we're all so sympathetically driven. So anything where you can drive that down a little bit and increase the parasympathetic influence of the nervous system,
Right.
the better off they're going to be.
And when you say sympathetically driven, we're talking sympathetic nervous system, fight or flight response.
Mm-hmm.
These are people who are typically on edge a lot, have difficulty managing stress
Mm-hmm. Yeah.
because of just the nervous and hormonal,
Right.
lockdown they've put themselves in.
Right. So teaching them these breathing strategies that they can do throughout the day is extremely important, and it's cool to identify those patients right off the bat because giving them they really like the breathing, they can respond well to it. And then
Right.
I'll like headspace a headspace app, some sort of mindfulness where they can, mindfulness or meditation, so they can have an excuse to work on this breathing and calm things down a little bit.
Sure. What is this? What is this Headspace app? I'm not familiar with this.
Yeah, so there's been a big upsurge of people experimenting with mindfulness and meditation. The way I heard of it was through Tim Ferriss. He has a really, really popular podcast. He's a best-selling author of The 4-Hour Body, 4-Hour Work Week,
Okay.
his newest book, Tools of Titans. And he interviews a lot of top performers throughout many fields. And one thing they all have in common is, I shouldn't say all, but most of them have in common is they have some sort of mindfulness or meditation practice throughout the day. So it's not what you think about, like, trying to hover over the floor, experience nirvana or anything like that. It's just
Right.
a time to be present, to focus on your breathing, to allow your mind just to focus on, to not really focus on anything, actually. So a lot of these people who are very high strung can respond really well to that. And Headspace, just trying to do it on your own is tough. Headspace is an
Right.
app that you can download, and it takes you through. They have great little. I don't get any kickback from Headspace, but it takes you through simple, 10-minute guided mindfulness, and it's great. With the stress of practice, I've found good benefit from it.
Oh, so you use it yourself
Yeah, totally. Yeah.
daily, or how often do you use it?
Yeah, I try to use it daily. It ends up being about every other day, every 3 days.
Sure.
I should do it every day, but I don't tend to do it on weekends because I'm just more relaxed on weekends. I'll do it on the weekdays before work, and they've got a lot of different kind of things. They've got like Headspace, mindfulness for pain, mindfulness for anxiety, for sleep, stuff like
Well,
that.
yeah. So as far as breathing goes, sometimes I get a patient in the exam room. I lay them down on the table on their back, and I say, "Go ahead and just breathe." And so I'm looking for, is their chest rising or is their belly rising? Are they a belly breather or are they a chest breather? And it's so funny because just last week I had two patients who had no idea how to use their belly to breathe. So they weren't using their diaphragm. I'm sure they were using it, but they weren't using it to its fullest extent, to its optimal measure.
Totally. That's a really common pattern that we see with people. I don't really know why, and I know I'm probably guilty of it too.
Absolutely.
And there is kind of maybe a miscommunication with words. People say, "Oh, I know I need to belly breathe" or something like that. But the way that DNS teaches it, DNS, dynamic neuromuscular stabilization,
Good.
the way they teach it is less so much of a strict breathing from the belly and more 360 degree. It must be Monday. 360-degree expansion around the torso, involving the lower ribs, even involving the chest, expansion of the chest. It's just less of a up and down of the shoulders. That's what people tend to do, right? So our traps, our scalenes are not muscles, are not respiratory muscles. They're postural stability muscles. But we need this 360-degree expansion, and that's ultimately what helps. We mentioned the balance of this parasympathetic and sympathetic nervous system, but it helps core stability as well.
Great. I like that you brought up the upper traps and the scalene muscles of the neck because, are there two more commonly stressed out type muscles than the scalenes and the upper traps?
No, not at all.
Often we find those very hypertonic and maybe spastic in some cases.
Yeah. So you can rub on those muscles, and I do because it feels really good. But perhaps to make those long-lasting changes, we need to change the cause of it. And DNS would argue that it's from improper breathing or from this paradoxical breathing pattern that a lot of people adapt. And if we could change that, then we have a better fighting chance of releasing some of the tension that is found in the traps and the scalenes.
Absolutely, because breathing is much more of a foundational mechanism. And then everything else kind of falls in line after breathing. It makes sense that you need to breathe first.
Yeah. Gray Cook, who's the, founder of FMS, the functional movement screen, and the SFMA. He says if you can't breathe in a position, you don't own that position, which I think is really cool. And he can help guide us in our rehab too. Is a patient ready for this position? Well, can they breathe in it? Can they, like we said, do they have that 360-degree expansion? Can they, keep their rib cage oriented, properly over their pelvis?
Right.
If the answer is yes, then sure, they own that position and you can move on. If not, maybe you need to work on it a little bit.
Absolutely. I love this conversation because we're kind of crossing that fine line over what is core, what is spinal stabilization, what is breathing, and it's interesting because it's all really the same thing.
Yeah. It doesn't have to be super complicated.
It doesn't.
Right? Yeah, you just need to know the basic patterns and apply it to the people you have in front of you.
Yeah, and then using the rib cage as as a gauge for core strength or proper breathing. That's probably the easiest place to look, because if someone's ribs are flaring out, we know that their abdominal canister, their diaphragm, pelvic floor, all the muscles that surround the front, sides, and back of the abdominal cavity, they all need to work as one. And then we know that if the ribs are flaring out, that we have an issue right in the primary location.
Totally. Yeah. That term abdominal canister is fantastic because it kind of gives people that perfect image. You can almost think of quote, the core as a can, where the diaphragm is the top of the can, the pelvic floor is the base of it, and the abdominal wall is the walls of the can. And what would be a more stable can? One that's dented and where the top is angled up, or one that's not dented and it's and the same can go with the core. So or the positioning of that abdominal canister. If the ribs are flared up, maybe the muscles in the back are taking a little bit more stress than they should, and you're not maybe that's not the most ideal position for certain movements.
In the past few weeks, I've had a lot of patients come in with shoulder complaints. I don't think that's their primary complaint that brings them in, but of course, going through an exam, I find out that they might have pain in one shoulder or even both shoulders, and so it's sometimes difficult to to get a patient to understand how your spinal posture affects that, how your breathing affects, shoulder posture and movement. If you wouldn't mind, would you kind of give me your thoughts on that whole process?
Sure, sure. So the shoulder, speaking, the glenohumeral joint
Yeah.
is the most unstable joint in the body, right? So if the people liken it to a golf ball on a golf tee, where the head of the humerus is the golf ball and the golf tee is the glenoid. And then you have the scapulothoracic complex as well, which can be argued is a joint. So the the scapula will ultimately like control what the shoulder's doing, but that has to sit nicely on the thoracic cage. Yeah. And then what the thoracic cage is doing is going to influence the shoulder. So, if somebody is really kyphosed or really rounded out, they're going to have a difficult time lifting their shoulder over their head, and they're going to create irritation. They're going to jam things up in the shoulder. And you can make that simple point by having somebody slouch forward and try to raise their shoulder, and they're not going to raise it very high. Right. And if they sit up straight and try to raise it, they'll get significantly more range of motion out of it. Taking it even further away from the actual shoulder, if you don't have proper stability in your abdomen, if you're not breathing properly, if you're not bracing properly, that shoulder is less likely to perform its job like it should. Another good example to do with patients is you have them put their hand on their left side, let's say, and just pinch their stomach, and then have them raise their arm up in the air. And the first thing you'll feel, if they're functioning properly, is a slight contraction of their abdomen on that contralateral side, because your brain knows to stabilize the core before it lifts the shoulder. So that's just a really common thing that needs to happen. We need firing of the abdomen, and we need before the shoulder lifts, and then we need good motion through the thoracic spine as well.
That's amazing.
A lot of people come in with shoulder complaints. So let's take lifters, for instance, like CrossFitters. They'll get a lot of shoulder complaints. One common thing you see with CrossFitters is that flaring of the rib cage, like you were talking about, this open scissor position where their backs are very arched, just because they're always in that big position where their chest is up and arms are out. Okay, and that can create some issues if they're not controlling it right. It can create some back issues, some low back issues, and it can cause some shoulder issues. A lot of these CrossFitters do have the mobility to get overhead. They're just not controlling it very well. So we will work on this core stability, keeping the rib cage down and then lifting the arm overhead. Sometimes they can't do that standing up. They have the mobility, they just don't have the motor control to do it. So we'll take it to an easier position. We'll have them lie on the floor, on their back, with their feet up against a wall. And I say, hey, what position are we in right now? We are essentially in a horizontal squat, or a horizontal, overhead squat. And then we have them go through the motion, and we lock it in while they're on the floor. And then we move it into more difficult positions. So we're going back to that. Can they breathe in the position? If they can, when they're on their back, then they own it, and then we can move it to a more difficult position. And if they can do it there, then we can move it to standing. And then once they can own it standing, then they're good to go.
That's great.
So took a huge turn from the shoulder a little bit, but it all comes back because it's where is the issue actually? Does the shoulder need an adjustment when it has pain going overhead? Maybe. Or maybe we just need to work on the position of the core. The shoulder is pretty inherently unstable as it is. You will get some stiff shoulders, but I don't know if it tends to be, with the exception of adhesive capsulitis, I don't know if it tends to be like articular tightness or just tissue tightness. I think it's more likely tissue tightness than it is tightness within the glenohumeral joint, AC joint. A lot of times you will have real sticky scapulothoracic articulations, but I think it tends to be more soft tissue.
And I'm with you there. Like soft tissue tightness, as in, man, the rotator cuff it seems like any patient with a shoulder complaint, shoulder pain, shoulder,
Mm.
it's frozen shoulder, whatever. It just seems like the rotator cuff is always involved, and if he's not always
Oh,
involved, he's like the number two in line.
totally.
Yeah.
Yeah. Yeah. And that, there's a lot of studies that say when you grip with your fist, you are activating the muscles of the rotator cuff, because when you are going to pick something up and you use that, you grip it, your brain says, hey, I need stability in the shoulder to do this. So it reflexively contracts the muscles of the rotator cuff. So a good idea to keep in mind when rehabbing somebody with those rotator cuff issues is grip strength, or working on drills that involve the hand gripping things, like bottom up kettlebell.
I love the bottom
Carrots.
up. Yeah, yeah.
Yeah,
You're
they're fantastic.
balancing the kettlebell here. Good.
Yeah, yeah. And tell them to try to squeeze water out of the handle of the kettlebell. Have them really squeeze it. And it's not going to hurt the shoulder doing it,
Right.
but it will activate those muscles of the rotator cuff.
That's a really good cue. And then staying with the rotator cuff specifically, I'm sure we both go to the gym fairly often, and we see people doing, they might be strengthening their rotator cuff in external rotation, and then they might be strengthening it in internal rotation. Um, I don't really like the concept behind that, because what does the rotator cuff do? It stabilizes the humeral head.
Hmm.
It's not. It's
Yeah.
not. Of course, it's taking your humerus, your arm, through a range of motion, but
Hmm.
it doesn't really need to be that strong. It just needs to be stable and then balanced.
Sure. Yeah, I think that goes back to the functional tasks of the rotator cuff. Like you said, it is to keep the humeral head in the glenoid. It almost acts as like that suction.
Yes.
So if you're trying to do a functional task for the rotator cuff, no, probably those aren't the best kind of thing. If rehabbing a rotator cuff, then maybe it is. Maybe it is a fine thing to do, because those are the actions. You do have internal and external rotators within the shoulder cuff. So within the rotator cuff. So let's say somebody has, a rotator cuff tendinopathy. The first thing I will prescribe, especially if they're super hot, are isometrics into internal or external rotation,
Good.
because it's one of the most simple things that they can do that will fire the muscles and will have a pain decreasing effect. As unsexy as it is, it's not a cool like bottom up kettlebell press with a band pulling them to one side or whatever,
Right.
but it's extremely effective. So it's all right. Yeah, if you're not injured and you're trying to build strength, why are you wasting your time with shoulder internal external rotations? Totally agree with that.
Yeah.
But if you are injured, if you're rehabbing a rotator cuff, the research says that stuff tends to be pretty good, going from isometrics into maybe some eccentrics, stuff like that. It can be really good. But in the long term, no, you want to get them back to activities that actually involve the rotator cuff in a way that they'll use it throughout the day.
Right. In a more functional process,
Totally. Yeah.
as compared to, standing at the cable, machine, or the cable tower, and
Yeah.
then we're
And how
laterally
boring.
bending, we're rotating, and then we're barely using our shoulder.
Yeah. 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 And that's the most boring thing in the world. So,
Absolutely.
if you like it, fine. But I don't know anyone who does.
And it seems like you do things very smart in your office. I can tell. I like the words isometric. I love the word eccentric, because you're not only working whichever muscle or whichever fascial line you're targeting. You're not only working that in its simplest concentric manner, but you're trying to get more specific, more advanced with eccentric and isometric contractions.
Right, right. Yeah, incorporating more isometrics has really been a game changer, because you get people coming in with injuries, and you can always find a movement that aggravates them, especially if they're a lifter or a runner or something. They'll tell you, yeah, like pushing hurts my shoulder. Okay, then what will we do? We will do isometrics pushing.
Good.
So all I have them do is push against the wall with their fist, and it's not moving the muscle through a range of motion. It's not moving the joint through a range of motion, but it's contracting it enough where they're getting blood flow to the area.
Yeah.
They're still working it, so it's not like they're having to take time off. It's a fantastic thing to do with these people, and then you can work through different ranges of motion. So if they're a power lifter and they have pain, real low in the bench press, you can have them do isometrics here standing, right? Maybe it's a little threatening laying down because that's the position it hurts in,
Right.
but you can have them doing it here standing and work through these ranges of motion. And then move them through different, if they're ready for eccentrics, do eccentrics, and then you can get them onto their lift better. Makes so much more sense in my head, at least, than just rubbing out the pec or rubbing out, the muscles around the shoulder, because it feels good, but it's temporary.
No, and I really appreciate your thoughts on all this stuff. I like the fact that, again, it's not only what can I do for the patient, but how can I make the patient stronger themselves, and then how can I educate them to become their best advocate for movement and just health in general.
Sure, absolutely, yeah. And I'll throw one more thing in. I think a lot of people might say that giving them too much, giving them too many tools, or trying to decrease the amount of time that you're seeing them will, in the end, decrease your PVA or your patient visit average or your overall collections from a specific patient or just in general. And I would have to disagree with that, because you're providing the patient with a much better service, and they're more likely to come to you with more issues in the future or send their friends or family to you. So, providing them with this great service where you are not keeping them on, signing them up for these huge long treatment plans like some of these old school people like to do. I think they really like that, and they see you as the go-to guy or girl for their issue or issues in the future. So it's the best kind of least sleazy thing to do is just to give them the best service possible and give them what they need to do their own thing. And if it means they come in and see you twice and then they're done, that's fine, right? You got somebody better in 2 visits and they're gone. They're gonna remember you as the guy who fixed their shoulder in 2 visits, as opposed to 6 months of care.
Absolutely. And I've talked a lot to other providers about this idea that if I can't really provide care if I know that this isn't worth the patient's time. If I'm doing something that I don't 100% believe in,
Mm-hmm.
it's not going to be good care. So
Right.
So for myself, I've learned that I need to do stuff that I'm really good at, that I 100% believe in, and then if that works, leave it alone.
Yeah, totally. I agree with that 100%.
Good. Dr. Sankey, it was awesome talking to you. I learned a lot. I hope you did as well.
Me too. Yeah, absolutely. Thank you very much. This is an awesome conversation.
Good.
We should have another one in the future.
We should. I'll talk to you soon.
All right, man.